Good afternoon, everyone, and welcome to the VCU Department of Internal Medicine Grand Rounds. Today's session is sponsored by the Division of Cardiology. And before we get into the introductions, just want a couple of housekeeping items. We are remaining virtual for the remainder of this spring session, and we'll return likely to a hybrid format in the fall. More to come on that. We want to encourage in the virtual format the Q&A session, so you have different options of submitting questions to Dr. Vetrovec. You can either use the chat function, the Q&A, or raise your hand, and about 5 minutes at the end of the session, we will have a back and forth dialogue. If you run into technical issues, you can either message Thomas or myself, and we will be available. Lastly, the session is recorded and will be posted on the website, and your CME code will again be posted at the end of the session as well. So today's session is sponsored by the Division of Cardiology, and it is titled Current Guidelines for the Management of Stable Ischemic Heart Disease. And we are pleased to welcome Dr. George Vetrovec to the medical grand rounds. I'm going to turn it over to the chair of the cardiology division, Dr. Gregory Hundley, for introductions. Thank you.
Thank you so much, Christian, and welcome to everyone today. Thank you, Dr. Syme, for providing this time for us to all gather. So important to have internal medicine grand rounds where we can get together as a community. And I couldn't be more thrilled and really privileged to have the opportunity to introduce to everyone today the speaker, Dr. George Vetrovec. Dr. Vetrovec's past, he went to high school here locally at Highland Springs. He went to college and medical school at the University of Virginia, and then he did his internal medicine and cardiology fellowship training here at VCU. From there, he joined the faculty, and over the years, from 1976 through, I guess, about 1986, rose from assistant to full professor. He was the chief or the chair of the cardiology division for 18 years, and he directed the catheterization lab for more than 30 years. And I want to spend just a minute and tell you a little bit about that. When Dr. Vetrovec started into cardiology for ischemic heart disease that required therapeutic interventions pertaining to relief of coronary artery stenoses, the main therapy at his time was coronary artery bypass graft surgery. And Dr. Vetrovec became a very early adopter, really one of the pioneers within the United States of a process, percutaneous coronary angioplasty. So crossing a stenosis using a catheter-based technique and inflating a balloon and trying to open up that stenosis and improve blood flow to the left ventricular myocardium. And honestly, within the American College of Cardiology, was one of the national and international spokespersons for that whole process. Just a really dynamic world leader. And we are so proud that he chose VCU here and for all of us to be a part of that. So without further ado, we will turn this over to Dr. Vetrovec. Thank you again for spending your time with us today, and we look forward to your presentation.
Thank you, Greg. This is, I have a little concern because I think I'm doing the intern conference next month on how to give a presentation. So I figure everyone's grading me today ahead of time. So hopefully this will be very crisp and succinct. But my purpose in doing this is I know internists are seeing patients with chest pain, stable chest pain in the clinics regularly. And there have just been two recent guideline updates, one for the management or the diagnosis and management of chest pain, and one on revascularization strategies, which interrelate with obviously the diagnosis and management that you do in the clinics. And so I thought it would be a good opportunity to touch on some of the highlights of the guidelines. And as you know, the guidelines, the executive summaries of guidelines are sometimes 30 pages. So they're very difficult to work through. But to touch on some of the highlights of those and to give a little background as to how we got to where they are today. And so hopefully it'll become a little bit more of a living, if you will, document. With that in mind, let me just remind you that there's a lot of interest in cardiac disease, not only because it's a major cause of morbidity and mortality, but there's a significant amount of cost. This I just found is the 20 leading diagnoses for direct expenditures in the United States related to health issues, and heart disease, I think, is number 6 on the list and accounts for over $100 billion. So trying to manage this efficiently to get the best outcomes is really critically important, not only for patients, but for cost. This just gives you an idea of how prevalent it is. If you look, if people live long enough, they frequently develop cardiac disease. You see about 35% of the population, almost, of men at least, have coronary disease or heart disease by the age of 80. It's less for women, but still increases by decades. This slide also reminds us that an important part of all of the guidelines is not only kind of the general principles, but the importance of individualizing. And I think we've learned, particularly in the setting of the pandemic, the risks involved in not managing diversity well and being sensitive to that. And when you look at this, you see the marked variations in racial differences in patients with coronary disease. So with African-American males in particular doing the worst, but African-American females being worse also. So we really need to be focused on individual, and we'll talk a little bit about cultural issues and so forth. So I just want to make that point to start. So if you think about how we've gotten here, the early angiographic studies going back to when coronary angiography started, and that was when we first had a chance to kind of put anatomy and outcomes together, we quickly learned that in general, the worse the coronary anatomy, the worse the outcome. And as a corollary to that, the worse the left ventricular function, the worse the outcome, and a very important factor. So those two pieces of information are still involved, but how we get there and how we deal with that is a little bit changed. We learned when bypass surgery came along that better outcomes were possible with revascularization, but that was really focused more on the patients with the most severe disease. So this is really an important piece of that. Angioplasty came along, but has never really been able to win in terms of a survival benefit compared to bypass surgery or optimal medical therapy. It's excellent for symptomatic control, and probably in some patients, particularly patients who are surgical turndowns, it offers a good option. But it's not ever been quite as competitive. There are probably a lot of reasons for that. So that just gives a little background on this issue of using revascularization to try to improve outcomes, survival in particular. In terms of symptoms, PCI and bypass surgery are probably equivalent in terms of providing good symptomatic relief for patients who can't be managed with medical therapy. So with a little of that background, we'll make a couple of other points. One of the things that's recurrently been found is that the more ischemia a patient has on stress testing and the like, in general, the more likely they are to potentially benefit and generally have more severe disease. So there's been over the years a lot of focus on ischemia, and should we revascularize based on symptoms? Should we revascularize in patients just on the basis of the amount of ischemia they have rather than symptoms? And when does that make a difference? So this issue of ischemia has come along for a long time. It's doubly complicated in patients who also have left ventricular dysfunction. This is results of the so-called Stitches trial, which was a trial looking at patients with LV dysfunction and coronary disease. And with 10-year follow-up, as you see in this data, the patients with bypass surgery as opposed to medical management did better. So we've known that, again, the risk of LV dysfunction plus ischemia is a risk factor. And in this trial, the patients that particularly benefited were those that had the most severe coronary disease, and revascularization made the most difference. So we've been dancing all along with this ischemia, anatomy, and LV function as to how we recommend managing patients. And that's also led to have a lot of emphasis on the extent of revascularization that we do when we revascularize patients. Many people have thought that's one of the limits to coronary angioplasty, is that we don't often get as complete a revascularization as our surgical colleagues do. And this is just one such study showing that bypass surgery only has about 25% incomplete revascularization, whereas PCI may have as much as 50%. So this may be one of the limits with bypass surgery. So the real question is what is this risk of stable coronary disease relative to anatomy and ischemia? And that led to a trial that was called the ischemia trial that's been reported out in various stages over the last several years. And this was a trial sponsored by the NIH. The lead investigator was Judy Hockman at New York University. And the question was, should you revascularize patients, either with bypass surgery or PCI, if they have severe ischemia, regardless of the extent of ischemia, extent of symptoms that they had? So at least patients that had at least moderate ischemia on a stress test, is there a benefit to going straight to catheterization and revascularization rather than optimal medical therapy? And this has a lot of impact in terms of patients going through this. It also has a lot of impact in terms of cost. So an important study. The study design was to take stable patients, which is what we're talking about, with moderate or severe ischemia, which was determined by the site, but overread by a core laboratory. And the goal was initially to have, if possible, all of the studies done with nuclear imaging or echo imaging, some imaging, but ultimately, because of enrollment issues and in going into other countries, it was not always feasible. And there was a method in which you could use just ST segment changes, which is ultimately was involved. And so if the patient had a lot of ischemia, they got a CT angiogram to exclude, because they wanted no patients with severe left main disease or severe three-vessel disease, the group that still people would think probably ought to be revascularized. This was looking at moderate to severe ischemia, but not the worst coronary anatomy and not the worst left ventricular function. That is, they wanted an ejection fraction over 35% in these patients. And then once they fell into this category, they didn't have left main disease, they were randomized to either an invasive strategy It turned out mostly coronary intervention versus a conservative strategy. And this was, an important study in the sense that it would look at a group that wasn't quite as high risk. It was done at 320 sites, 37 countries. And interestingly, only 16% were enrolled in the United States. And one of the criticisms that it has had is that only a third of the patients looked like the patients that are in the large database for angiography in the United States and PCI, which is the NCDR. And there was a lot of variation between centers. So as always, it's never a perfect answer, but nonetheless, this is what was found. And so in terms of mostly 3, but it's extending out over time follow-up, there's really been no clear benefit in terms of a primary outcome of CV death, MI, or hospitalization for unstable angina, resuscitated cardiac arrest. If you look at the curves, what happened here, the blue line is the conservative line, the red line is the invasive line. Now, one of the things that complicated this was that the measure of heart attack was an enzyme measure, among other things. And so in the very early time frame around the procedure, there were heart attacks, most of which were very small and were enzyme related with a good prognosis after them. But nonetheless, the MI incidence was higher, or the event was higher. And then over time, what's happened is the curves have started separating again the opposite way, with worse outcomes slightly for the conservatively managed people. If you subtracted this initial out, there would be an advantage, late advantage to revascularization. But when you balance these two, it's a sort of neutral outcome and not statistically significant. Now, the plan is to continue to follow this so that maybe at 10 years, there will be a difference. Nobody knows at the present time. It looks null. And it's not statistically significant. And this is true of CV death and MI. It's true of net clinical benefit, if you look at all of it. And cardiovascular death is not significantly different, although again, it trends a little bit in that direction. So the real question is going to be over a long-term follow-up. There are limitations to the study, unblinded trial, there's no sham procedure. So based on exclusion criteria, it doesn't apply to every patient you're going to see. So acute coronary syndromes within 2 months were excluded. Highly symptomatic patients that thought would need something for their angina were excluded. Left main was excluded, and the low ejection fraction, as I said. So that limits the targeting. And I think the really critical thing is that the study doesn't say you never want to revascularize patients. You never want to look. You have to make these decisions about the severity of disease of the patient. And again, it may not be generalizable to the higher procedural centers and so forth. Completeness of revascularization may have benefit, and we'll touch on that in just a minute. And women were enrolled in the trial, but more often excluded from randomization compared to men due to less ischemia. They didn't trigger the entry criteria and less obstructive coronary disease overall. So the conclusion is that in terms of stable ischemic disease, overall an initial invasive strategy in this not most severe disease category did not demonstrate a reduced risk over median 3.3 years of follow-up in all of these endpoints. And so at the present time, there's not a clear indication that for basically any patient with moderate ischemia, they should be revascularized. Now, the issue about an invasive complete revascularization versus conservative management was looked at, and it was looked at both anatomically and in terms of functional findings. And there is a trend toward an improvement in outcome with better revascularization, but again, it's somewhat definitional. And what's tricky about it is that not all of the patients had complete revascularization, so the numbers get smaller in this. But it does suggest that. But I think a very important conclusion here is that it doesn't say you do it regardless. You really have to make a decision that suggests that you can do the revascularization with a low risk, and not just because you want to do the revascularization or think it's so important. So again, judgment is an important part of the decision-making. So in conclusion, for the revascularization, complete revascularization is associated with greater improvement in angina-related quality of life, particularly in patients with significant angina, and functional complete revascularization is at least as effective as anatomic in improving angina-related quality of life. Invasive management achieving complete revascularization improves angina-related quality of life more than conservative management, with greater benefits in the patients who had more angina. And stress-induced ischemia burden on non-invasive testing and presence of CTOs, that's total coronary lesions, do not identify patients who benefit more or less from complete revascularization. So again, it has to be very individualized in that circumstance. It's probably better than not doing it, but it's not the total answer. So patients with chronic coronary disease and angina who are being managed invasively, the safe achievement for complete revascularization will optimize quality of life at least. And now there are other studies that are meta-analyses that have shown different things, particularly, and there are other studies that have looked at LV dysfunction. And so there's a sub-study from the ischemia trial looking at patients with not severe LV dysfunction, but in the 35 to 45% range who have had a history of heart failure at some point. And when they looked at those patients, there actually was a benefit to revascularization, suggesting that revascularization, again, relative to LV function, is an important factor. So I, again, want to emphasize that as an important part. And so in these patients who had 35 to 45% ejection fraction, an initial invasive approach was associated with better event-free survival. And given that the study was not randomized for this, it's really hypothesis generating more than an absolute finding. And then the meta-analyses, as I said, looking at multiple studies, have shown that in the patients with the most severe disease, there was a benefit to revascularization. So I think as we go forward, we're seeing a lot more emphasis on really individualizing with particular attention to not just ischemia or not really ischemia, but more about the more severe anatomic disease, both coronary as well as left ventricular function. And I think this is going to have a lot more effect on decisions as we go forward. The last thing I want to show, which I think is relative to background, is this factor that the impact of optimal medical therapy on 10-year mortality after coronary revascularization. And I think patients and maybe even physicians sometimes forget how important it is to maintain what you've gotten in terms of benefit. This is looking at really treating patients well after revascularization. And if you look at antiplatelet drugs, statins, angiotensin-converting enzymes, et cetera, and beta blockers, if you look at the number of medications that patients are on in terms of that, the overall improvement in outcome, optimal medical therapy, is associated with better overall survival. So I think it's important that we really have a charge to maintain what we do. So the changing paradigm, as I see it, as we'll look now briefly at the guidelines itself, is that anatomy, the extent of disease, is becoming much more important in terms of the prognostic factor, seems to be more sensitive than ischemia as an indirect marker for anatomy. And the consequence of this is I think we're going to see greater use of tools such as calcium imaging of the coronaries and CT angiography to supplant stress testing in certain circumstances to try to identify the worst coronary disease rather than try to get that indirectly with ischemia. On the other hand, you will still use ischemia studies to try to document if the patient's symptoms are really related to ischemia. So I think we'll have to be a little more flexible as we go forward with this somewhat changing paradigm. And again, optimal medical management of risk factors and coronary disease remains important to really get the best we can. So as I said, stress imaging for symptom assessment, anatomic assessment, which can be done much better these days than in the past with CT angiography, and now the ability to even do flow measurements with CT angiography. All of this is improving to give us a better opportunity to distinguish severity of coronary artery disease. So very briefly, I'm going to touch on the two guidelines now with this background. How did we get here? This is how we got here. So this is sort of the guideline for the evaluation and diagnosis of chest pain. And I've restructured it just to focus on the parts of it that have to do with stable ischemic disease. So some take-home messages. Chest pain means more than pain in the chest. And we all know this, but I think it's worth reiterating that pain, pressure, tightness, discomfort in the chest, shoulders, arms, neck, back, upper abdomen or jaw, and even shortness of breath can be markers of ischemia and coronary disease, which become very difficult and sometimes very subtle. My probably best recollection is the patient that I had early in my time who had recurrent episodes of earlobe pain in his left ear. And he kept complaining, and I put him on the treadmill, and when he got to peak exercise, he got left earlobe pain, and it turned out he had significant coronary disease. So not everybody's going to have earlobe pain, but the point being, we really have to be thoughtful about not only what the exact symptom is, but what the characteristics of it are that might suggest angina. Now, shared decision-making is really important, and we talk a lot about team work in terms of deciding. And the patient should also be included in this decision-making pathway because we're really talking about cost, we're talking about risk. And so we want to make sure that the decisions we're coming up with are reasonable, and that particularly if they're complicated, other people agree with us, and that the patients understand and appreciate the thought, their input into it. And again, we focus on chest pain, but excuse me, we have to be sensitive to the fact that different people have different thresholds, and particularly women and with acute syndromes are much more likely to have nausea or shortness of breath. And then the other point is that there's a lot more emphasis now on not just cathing everybody or doing stress testing on everybody, really trying to see which patients will benefit from further evaluation. If they're really low risk, they don't need anything else. But we need to be very careful, not that we don't miss patients that are otherwise higher risk. So the other message here that I think is helpful is this old concept we talked about is, oh, they have atypical symptoms. I think people have come to now say the approach to think about it is it a non-cardiac symptom in which cardiac disease is not suspected, or is it, or if one uses the term atypical, it could be misleading as a descriptor of chest pain. And so it's now not the fashionable term to use. And again, patients need to be evaluated in a kind of structured, logical approach. And again, considering the options. And I like this diagram here. This is the concept of your suspicion for chest pain. Is it ischemic or is it non-ischemic? And if you look on the high risk side, on the left-hand side, central pressure, squeezing, gripping, all the things we learned in medical school. And then as you come across, you start getting vaguer and vaguer symptoms. It's sharp, it's fleeting, it's shifting, it's pleuritic, it's positional, as a low risk. And I think this is our challenge always in terms of trying to figure this out. And again, the problem we face is the uniqueness of women's chest pain and trying to not miss that and underinterpret it. So it's important to really be aware that the presentations are different, and many times the coronary disease is somewhat different. So very important part of what we do. The other group of patients that are a little trickier are older patients. And older patients are much more likely to have shortness of breath as opposed to the typical angina symptoms. And at least when they present with an acute episode, they can have some really bizarre things with syncope and things like that as a manifestation of ischemia. And lastly, I made the point earlier about the diversity and differences in risk factors and different risk factors that are socioeconomic and various things. So we really need to be very aware of that, and we need to make decisions related to thinking about the culture and the circumstances. And we have an increasing number of populations in which English may not be their primary language. So there are a lot of challenges in terms of dealing with diverse populations to make sure we do the right thing and the best things we can. Some stress testing considerations. Excuse me. If you look at this pyramid, I kind of like this, if you patients are asymptomatic, they may need no testing if they're doing well. I would say that one of the things that I think is always helpful when you talk about the asymptomatic patient, you also have to consider how much they do. Do they do enough to become symptomatic? So I would sort of at least make sure that their exercise performance is okay. And you can work your way up with the different things. And the most unstable patients and the highest risk patients based on either anatomy or stress testing and the like are those patients that are high risk, and then they probably will benefit from a coronary angiogram and consideration as to whether or not they need revascularization. So in terms of the evaluation of patients with stable chest pain, a couple of other things. Low-risk patients with stable chest pain and no known coronary disease, one of the recommendations is that these patients really don't need a lot of additional testing unless there's something new or different about them. I think, again, this is the emphasis on not trying to overtreat patients who are otherwise doing quite well. And I still think in talking to patients what their exercise performance is and how much it's changed or not changed is very helpful in terms of knowing their stability. And if you have stable chest pain, even if they have known coronary disease, again, it's a lot in terms of how much they have changed or can do. And if they're stable, they may not need anything or maybe just a functional sort of test. Now, in patients who have no known coronary disease, but are intermediate or high-risk patients, CT angiography is probably a good way to screen for high-risk coronary disease to help in deciding about do they need angiography and the like. Again, other tests are possible, PET scans, stress nuclear studies, but again, this is this balance between is ischemia what we really want to know or do we want to know anatomy? And I think the higher risk the patient, the more some form of anatomic assessment and certainly assessment of left ventricular function is important. In terms of patients with stable pain, no known coronary disease, other considerations are the continued consideration of stress tests. But again, this emphasizes here, if you read through this, the extent of exercise performance, which I think is another subtle piece of information that's very helpful in terms of patients. So when you look at them, did they have ischemia? How far did they go on the treadmill? I think that's as helpful to me. And there are some studies that support that how long you stay on the treadmill is a very good predictor. And then finally, the issues of whether they have LV dysfunction, other valve disease, and so forth are, again, helpful in terms of deciding what you need to do. Now, in patients who are high risk, then you're more likely to move to anatomy and or angiography, particularly if they're very symptomatic. Again, we're trying to get to the patients that will benefit the most with the least testing, but not missing patients that could do better. Now, in terms of choosing tests, again, I think it's important to not only do the high and low risk consideration, but even in choosing a test, if somebody can't walk, you can't get a decent exercise stress test. You've either got to use perfusion imaging or you're going to go to a CT angiogram, something else. So assessing the patient is, again, an important part of what you need to do in terms of deciding what they do. So I think that's an important consideration. I'm going to skip ahead and give you some take-home messages, just a couple about revascularization. The revascularization considerations are that, again, this is where it becomes very important in the most complex anatomic situations or patients with diabetes and so forth to have a surgeon, a cardiologist, a heart failure doctor if they have heart failure, the internist who's managing the patient to know what the patient's goals are. I think it's important to get as many people together as you can for the decision making. Obviously, if somebody has a left main disease, surgical treatment is the optimal treatment for that if the patient can tolerate it. There are circumstances in which intervention have to be done. Contemporary trials suggest that in patients with the most severe disease, again, revascularization makes a difference. And again, I mentioned the heart team with diabetes and multivessel complex disease. These are all important decisions, and to make them fit what the patient needs and also wants. So there's informed consent to make sure the patient understands, but there's also getting the right treatment for that patient and the shared decision-making about what's appropriate. Few things about the pre-procedural use of the heart team. You can think about shared decision-making and so forth, and then tailoring this to specialized population. And finally, cardiac rehab and all the things afterwards, smoking cessation, so forth, are all important in managing it. Now, a couple of things lastly about revascularization. And revascularization to improve survival, I think there are a few caveats that are important. Again, left ventricular dysfunction and multivessel disease, revascularization. Multivessel disease alone with three vessel disease, likely bypass surgery, likely will do better, not an absolute, but is generally thought to be reasonable. In terms of patients who have to reduce cardiovascular events, again, with the most severe disease, the thought is that these patients may benefit from revascularization. I suggest that in the future, we're going to have the tools with imaging to make decisions about the instability of the lesions or the potential prognosis of the lesions individually, which may really help with these decisions in the future. In terms of improving symptoms, if somebody's really disabled from their angina or significantly limited and it's not manageable with medication, this is a good consideration for revascularization. Older patients are a little tricky. You have to understand what their goals are, what their other risk factors are, what their life expectancy is. And particularly, I think when you start talking about bypass surgery in elderly patients, you have to think about what the risk may or may not be to their long-term cerebral function. And so I think it's very important to really individualize these decisions. Now, one thing that always comes up, we get pushed by the, and I know we all live this, the surgeons say, oh, this patient's going to have a big operation. We want you to fix their heart first. And this is just a really big challenge. But in general, in the absence of left main disease or severe multivessel disease, there's really not evidence that revascularization makes a difference for non-cardiac surgery. And in fact, doing angioplasty and then having to be on antiplatelet agents, which will delay surgery, is actually probably more harmful to the patient sometimes in deferring surgery that needs to be done. So I think that's an area that needs to be paid particular attention to. So again, the secondary management of the patients in terms of cardiac rehab and education, smoking cessation, managing psychological issues, particularly after they've had interventions. Some people get depressed and so forth. And risk factor medical management are all critical to making whatever revascularization decision have the optimal benefit for the patient. And I think these are factors that it's easy to forget, but they really make a difference in terms of getting the optimal benefits. So in summary, I think the evolving guideline management focuses on identifying circumstances in which revascularization makes a difference in terms of symptoms or survival, and that doesn't apply to all patients. The current testing today for ischemia is focused more on high-risk anatomy and less on ischemia. So we're not just doing a knee-jerk, oh, ischemic on the test, needs a stent, needs a bypass. In the future, emphasis may focus on plaque morphology, as I said earlier, to identify risk of the plaque rupturing in the future and what that potential is. And patient management decisions are complex. The heart team is an important part of all of this in terms of identifying patient culture, education, goals, and the best treatment to match all of that with more minds than one making that decision. And I think that's very helpful, and that's where the internist, the cardiologist, the cardiac surgeon, sometimes a heart failure, a group of people get into making those decisions. And I think that's really leads to optimal patient management. So I'll stop at this point, and I'll be glad to answer questions for you. And that should put up, well, did it put up the, it didn't put up the sign. Questions?
No problem. Thank you so much, Dr. Vetrovec. That was really thought-provoking and I think very comprehensive. So thank you so much. I see one comment in the chat box here, and if the author wants to unmute and maybe expand, it says, revascularization benefit with left ventricular dysfunction. Is this the CAS trial all over again? Any comments, thoughts?
Well, I guess it is. It is interesting that the CAS, the CAS trial, for those of you that are a little younger, the CAS trial was done fairly early in the days of bypass surgery, looking at the advantages of surgery. And it turned out that in there, the patients with LV dysfunction tended to get better benefits with revascularization than just patients with coronary disease. So I think preserving LV function in those settings is important. So maybe it is the CAS trial all over again, but I think over the years, we've continued to be focused on the benefits of revascularization in patients with compromised ventricular function. I still don't think we always do a good job of it. I see patients a lot of times that no one's ever looked at their LV function and so forth. So I think that's an important issue.
Thank you. Another question here in the chat box. How do we get insurance companies to pay for these alternative tests for coronary artery disease? Most of the time, they only want to cover treadmill stress tests. Comment?
I think that's true, and I think what happens, there's always the delay between the insurance companies catching up with the guidelines, and this is going to be a hassle for all of us. But I think they'll figure it out if it, and the guidelines are clearly driven by trying to target people who benefit. So when the insurance companies figure out that it may save some procedures that don't benefit patients, I think that'll help them get on board.
Dr. Vetrovec, thanks for just a great summary. Can you talk a little bit about some of the emphasis on differences in cardiac disease and management in women? I think there's been a lot of interest. I know some incredible.
Yeah, I think it's very tricky. There's a lot of data being generated now, and not all of it's put together, but it looks like women have a lot of symptoms that we used to think were atypical or not even ischemia that are ischemia in the absence of severe major vessel coronary disease that's related to vasoreactive disease in the smaller blood vessels of the heart. And there's an increased number of patients that are, a number of studies that are being done where you actually look for vasoreactivity in the vessels to help identify which patients will benefit with oftentimes different types of treatment. So I think that's one thing with women. The other with acute syndromes that they present with is this phenomenon called SCAD, which is the spontaneous coronary artery dissection And that's actually managed a bit differently, except for unusual things. You usually don't stent it or do anything with it if it's stable. Sometimes you have to, but so this is a separate thing that's pretty unique to women. So I think we're getting smarter, but it's taken a while.
Thank you.
I have a comment regarding to my own practice. I practice predominantly in nursing home patients, and just a comment and then maybe your reflection. There's younger and younger residents of long-term care facilities. Not all of them are over the age of 85 with a limited life expectancy and chronic diseases, and lots of health system implications in terms of heart failure management. But multiple studies in the last 5 to 10 years have shown a decreased recognition of coronary artery disease in the younger age group, 65 to 75, residing in nursing home and long-term care settings without a primary diagnosis of dementia and a life expectancy, greater than 7, 8 years. The question is, what kinds of things could be done to promote recognition, education in settings that are potentially resource poor. So nursing home setting is just one of them, rural centers, critical access hospitals, and other settings. Any comments around that?
I sort of touched on it in the talk, but I always tried to, I even tried to educate patients to be aware of sudden changes in exercise performance. I mean, it's clear that when you're 75, you can't do what you did when you were 40, but that took, 35 years to get there. But somebody who, 3 months ago could walk up 2 flights of stairs slowly and do fine, and now can only go up about a third of the way of one flight and has to stop, and a lot of times I think senior people tend to kind of blow that off saying, oh, I'm just getting older. So I think that's I think exercise performance is and not exercise in the true sense, but just activity performance is an important part of it. I would use that as a very helpful indicator. It's pretty cheap too.
Yes, certainly. Thank you so much. Any other comments, thoughts, questions from the audience? Dr. Vetrovec, any comments for our trainees on the audience?
Well, I really would encourage you that the history is very helpful, as we talked on some of the things that are important in terms of exercise, in terms of being sensitive to the fact that women's presentations are different, to be sensitive to the cultural issues or language issues that may make it difficult to get a history. Having gotten through all of that, I do think that we don't do a good job of when a patient has a problem, such as heart failure, and necessarily working it up well, and or shortness of breath, and making sure that they don't have coronary disease. So I would encourage selective use of testing to make sure you're not missing important parts of the anatomic disease. There are some really interesting studies in the heart failure literature. Patients come in with heart failure and never get screened for coronary disease. And it turns out that at least 50% of those people have severe coronary disease, maybe higher. So we're not doing that as well as we could.
Dr. Syme, any comments?
No, just want to thank you very much, George, for all your contributions to VCU in the past and ongoing, because I know you're still very active in helping us out in lots of different ways. So thank you for all the foundations that you've laid to make our cardiovascular physicians and nurses and everybody so successful. Appreciate it. All you've done.
Thank you for having me.
Well, thank you, everyone. Thank you, Dr. Vetrovec, for an excellent talk and discussion. We really appreciate that. And to all the audience members, thank you for participating. CME code should be on in the chat box now, and the lecture will be recorded and on the website. Thank you so much on behalf of the Department of Internal Medicine. Thank you, Dr. Vetrovec, for an excellent talk. We look forward to welcoming you back at some point in the near future.
All righty, thank you. Bye-bye.
Bye.